Good morning, all. Myself, Dr. Raguraman, Assistant Professor, Department of Radiology, and I'm going to do a presentation on hypolucent hemithorax in chest radiograph. The hypolucent lung is the one that has increased lucency compared to the other lung on chest radiograph. So this hypolucent hemithorax is we can able to see commonly in our chest X-ray. So before investigating the causes of hypolucency, it is important to establish whether the apparent unilateral hypolucent hemithorax is truly too lucent or if the contralateral hemithorax is too opaque. So this appearance can result from wide variety of technical factors and various diseases. The causes of unilateral hypolucent hemithorax includes technical causes, causes related to the chest wall, pulmonary vascular abnormalities, lung parenchymal abnormalities, which may be affecting the ipsilateral side or they may be affecting the contralateral side, and central airway abnormalities, mediastinal and pleural space abnormality. Among these causes, the most common cause is the technical causes. So, before interrupting any chest radiography, we have to rule out the technical causes first. In technical causes, the most common cause of unilateral hypolucency is patient rotation. When chest X-ray is taken in rotated position, the X-ray transmission increases due to short tissue distance which passes through, and that region become more hyperlucent. As well as other technical causes includes incorrect centering of the X-ray beam to the grid, unequivocal compression or positioning of the chest wall soft tissue against the facet. So this unequivocal compression or positioning of the chest wall soft tissue leads to unilateral hypolucency. Coming to the other causes, that is chest wall abnormalities. The chest wall abnormality may be due to iatrogenic following radical mastectomy in a patient having ipsilateral breast carcinoma. So the treatment for that will be going for radical mastectomy. So the X-ray penetration distance in that side, affected side will be less, leading to unilateral hypolucency. Or this chest wall abnormality may also seen in case of normal people with some professionals, which give rise to asymmetric chest wall musculature, which is most commonly seen in case of butchers and carpenters, where they will be used to mainly to the right hand. So there will be some amount of muscular hypertrophy will be seen on the ipsilateral side, leading to unilateral hypolucency. As well as there is also atrophy of the trapezius muscles after radical neck dissection, leading to unilateral hypolucency, as well as in case of acute infective causes affecting the chest wall like poliomyelitis, or there may be congenital syndromes that is associated with muscular atrophy or dystrophy in case of Poland syndrome. This is a chest radiography of the female patient where we can able to appreciate the breast parenchyma on the right side, whereas on the left side the breast parenchyma is absent. So this patient had a previous history of a breast malignancy. For that, they had done left mastectomy. So in this chest X-ray, the left side of the hemithorax will appear more hyperlucent compared to the right side because of the absence of the soft tissues. Coming to the next causes, that is Poland syndrome. Poland syndrome is a non-hereditary condition characterized by congenital unilateral aplasia of the pectoralis muscle. The causes of Poland syndrome relates to the distribution of the blood supply to the subclavian artery distribution during the chest wall development in vitro. So in vitro development itself, there is some amount of reduced blood supply to the ipsilateral side, mainly affecting the subclavian artery, then to the chest wall, leading to the muscular dystrophy or atrophy on the affected side. The more frequent and sporadic types shows male and a right side predominance. The characteristic radiographic finding of Poland syndrome includes unilateral hyperlucency of the lung related to the lateral tissue of the chest wall. This is a schematic image as well as the chest radiography of a patient with absent right-sided pectoralis muscle shows that there is increased translucency on the right side of the lung parenchyma compared to the left side, whereas the pulmonary vascular markings, even though appears intact, because of the chest wall abnormality, this lung will appear more hyperlucent compared to the contralateral left side of the hemithorax. Coming to the other causes like of coming to the other causes of pulmonary vascular disease, which includes unilateral pulmonary agenesis or pulmonary artery hypoplasia. So in these conditions, there may be affecting the affected unilateral side lung development itself will be small. So leading to unilateral hyperlucency, or there may be extensive pulmonary artery obstruction secondary to tumor or maybe to lymph nodes, or there may be associated congenital syndromes like Hemithorax syndrome. Coming to pulmonary hyperplasia is associated with decreased number as well as the size of the alveoli, airway, and blood vessel, and it results from incomplete lung development. At chest radiography, the affected lung appears small or and may be hyperlucent. This hyperlucent may be due to oligemia as well as the contralateral lung may appear hyperlucent as a result of compensatory hyperexpansions. So, in case of pulmonary hyperplasia, the affected lung will be smaller in size in chest radiography, as well as the opposite lung will go for hypertrophic and air trapping also may be seen. So, the ipsilateral pulmonary artery usually appear diminutive and there may be associated with, most of the cases are associated with ipsilateral mediastinal shift. This is the chest radiography showing a hyperlucent as well as hyperexpanded left side of the hemithorax when compared to the right side of the hemithorax, where the right side of the lung will go is having pulmonary hyperplasia, and there is also associated mediastinal and shift and dextro position of the heart is seen. Usually the heart is will be located on the left side because of this compensatory hypertrophy as well as the hypoplasia on the contralateral side. There is also mediastinal shift is seen in this is radiography. Coming to Schmitter syndrome, also known as hypogenetic syndrome or pulmonary venolobus syndrome. It is a form of partial anomalous pulmonary venous connection that involves all or portion of the right lung. So the ipsilateral lung typically is hypoplastic, that means underdeveloped, and the affected hemithorax almost always on the right side with hyperinflated and hyperlucent contralateral lung. At radiography, the Schmitter vein may appear as a curvilinear tubular opacity which can be seen along the right side of the heart. This is a chest AP radiography of a 5-year-old boy with the Schmitter syndrome shows hyperinflation of the left lung with slightly increased vascularity, as well as there is a small right lung compared to the left with rightward mediastinal shift. So when you look at this chest X-ray with the naked eyes, it was looking like the left lung appears a little bit smaller compared to the right lung, and it is not because of this hypolucency on the left side, it's because of the pathology on the opposite side, that's the right side. Coming to airway disease, and the most common and most critical one is the pneumothorax, which is nothing but air collections within the pleural spaces, and the other causes includes asymmetric emphysema, bronchial obstruction due to foreign body or maybe due to the lymph node, bronchial atresia, or contralateral lung pathology. Coming to pneumothorax, pneumothorax is caused by alveolar rupture due to sudden increase in intrathoracic pressure associated with pleural tear. It may be secondary to the rib fracture, provided the rib has to pierce both the pleura and the lung so that the air can escape from the lung parenchyma in and collect into the pleural space. When this collection of gas is constantly increasing over the time with the resulting compression of the mediastinal structures, it can be life-threatening and it is known as a tension pneumothorax. In tension pneumothorax, there is a valve-like mechanism is there, so the air will be collecting only within the pleural space and there is no space for the air to escape from the within the pleural space, so leading to causing massive increase in tension and ipsilateral compression. So this is the critical condition and has to be diagnosed immediately and treatment has to be done. On erect chest radiography, pneumothorax is seen as abnormally increased lucency with a thin, sharply defined line that represents the visceral pleura. Lung markings are not seen beyond this line. This is the most important things in case of identification of the pneumothorax. We won't be able to see any bronchial markings or lung markings. In supine position, the air collects anteriorly and medially in anterior claustrophrenic sulcus. Why in supine positioning is findings is important is like in major cases there may be of a polytrauma, so patient may not be able to stand for taking an erect chest radiography. So we should also aware of the findings in supine radiography. The signs of pneumothorax on supine radiography are there may be abnormal increased lucency in lower chest wall or upper abdomen. Because of the unequivocal air collections, there may be increased lucency will be seen on the between the upper zone as well as mid zone on the ipsilateral side itself. And the other signs which we can see in pneumothorax includes deep sulcus sign, which is nothing but abnormally wide and deep claustrophrenic sulcus, as well as the double diaphragm sign, where the air outlines the dome of diaphragm and the anterior incision of the diaphragm, giving to the appearance of a double diaphragm sign. And the other findings which we can see in case of pneumothorax includes the sharply outlined diaphragmatic or cardiac border, as well as there may be associated depression of hemithorax may be seen. The left chest radiography shows the pneumothorax on the left side, giving the visceral pleural signs. So we can able to see there is absent pulmonary marking within the air in the left pleural spaces in case of pneumothorax, whereas the other lung parenchyma on the other side on the ipsilateral side also having shows the normal pulmonary markings. The chest radiography on the right side shows the pneumothorax on the left side with a deep sulcus signs. Coming to emphysema, emphysema is abnormal permanent enlargement of the air spaces that is distal to the terminal bronchioles, which is accompanied by alveolar wall destruction with or without fibrosis. So this is irreversible process. Mainly, this will be affecting the bronchioles distal to the terminal bronchioles. And in some cases, there may be associated fibrosis may be seen, and some cases fibrosis may be absent. So there is marked overinflation of the lobe, and most commonly it will be affecting the left upper lobe. And the ipsilateral lobes are compressed, and there may be mediastinal shift to the contralateral side may be seen. This mediastinal shift due to the dilatation and air trapping within the distal terminal bronchiole, causing some mass effect and displacing the mediastinum to the opposite side. This is the chest radiography of a 2-year-old boy of left upper lobe congenital lobar emphysema, where we can able to see the increased lucency on the left side of the hemithorax when we are comparing to the right side of the hemithorax, as well as there is a mediastinal shift seen shifting the cardiac shadow to the right side of right hemithorax. And this is a case of congenital cases, congenital lobar emphysema. Coming to bronchial atresia. Bronchial atresia is a congenital anomaly that results from focal obliteration of proximal segment or subsegmental bronchus without a communications with central airway. So this loss of communications with the central airway as well as the preserved ventilation via collateral pathway leads to air trapping and hyperinflation. So this in case bronchial atresia, usually there won't be no communications to the central airway will be seen. However, they may receive the air communications via the collateral pathway. And this air won't help in gaseous exchange, whereas leading to air trapping as well as hyperinflation. The characteristic radiographic appearance of bronchial atresia is round or oval branching opacity which will be radiating from the hilum representing bronchoscopy, and it may be associated with areas of hyperlucency in adjacent lung parenchyma. The upper lobe bronchi are more frequently affected in case of bronchial atresia. This is a chest radiography. Frontal view shows increased lucency on the right upper zone compared to the other regions of the lung parenchyma, as well as there is also associated right paratracheal mass-like opacity. And when you clearly see this hyperlucency, it seems like it is extending from the right hilar region and extending up to the periphery. So it's a case of bronchoscopy in bronchial atresia. Coming to congenital pulmonary airway malformation, this congenital pulmonary airway malformation, shortly called as CPAM, is a developmental anomaly characterized by disorganized hematomatous and adenomatite proliferation of primary bronchioles that communicates with the bronchial tree. About 85% of the patients with the CPAM become symptomatic in the neonatal period, leading to respiratory compromise or recurrent pulmonary infection. So, this CPAM patients following delivery, they may be going for acute episodes of respiratory distress needing NICU admission, as well as they may be presenting with recurrent episodes of lower respiratory tract infections. The radiographic appearance of CPAM depends on the number and the size of the cystic spaces forming the lesion and whether there is a superimposed infection is present or not. The most common imaging finding is an area of hyperlucency that is usually confined to the one lobe because the cystic CPAM may be localized to the involvement of the segment, leading to the hyperlucency also will be localized to the one segment. This is a chest radiography of a CPAM patient showing hyperinflated and loosened right side of the hemithorax with multiple cystic separations noted within it. So in this case, the right side of the lung is predominantly involved and it appears hyperlucency, and this cystic thing also wall also we can able to appreciate in chest radiography. Coming to Sever-James syndrome. Sever-James syndrome is a condition characterized by unilateral hyperlucent lung that usually develops during childhood, and it is occurs as a sequelae of post-infectious bronchiolitis obliterans. So this Sever-James syndrome is an acquired condition that may be due to infectious etiology. So this causes narrowing of the bronchiolar lumen due to the fibrosis, which reduces the ventilation and leads to compensatory hypoperfusion of the affected lung. This process also results in hyperexpansion of the peripheral airway, which contributes to hyperlucency seen on imaging study. The characteristic radiographic findings of Sever-James syndrome consists of Asymmetric hyperlucency of the lung or lobe associated with small hilar shadows, and it is also associated with other findings like small pulmonary vessels and bronchial wall thickening and bronchiectasis. Air trapping can cause some mediastinal shift towards the affected side on inspiration and mediastinal shift to the opposite side during expiration. This is a chest X-ray radiography shows increased lucency on the left side of the hemithorax when compared to the right side of the hemithorax in a case of severe James syndrome. And we can also see small hilar shadows that may be indicating mediastinal lymphadenopathy. And when you compare the pulmonary vessels diameter on the left side and to the right side, the pulmonary vascular markings on the left side appears smaller in case of Shiva-James syndrome. Coming to bronchial obstructions, it may be the obstructions in the bronchus may be due to an extrinsic factor or may be an intrinsic factor. The extrinsic factors may be due to the enlarged lymph node that may cause partial obstruction or distortion of the airway, or there may be uneven aeration resulting in unilateral hyperlucent lung due to underlying air trapping. Foreign body aspiration is most common cause of intraluminal airway obstruction in case of children. And most commonly that will be affecting the right side of the bronchus because of the anatomic positioning of the right main bronchus. This is the frontal chest radiography of a of children showing increased lucency of the right side of the hemithorax compared to the left side of the hemithorax because of the air trapping happening in the right side of the hemithorax due to foreign body ingestion that is obstructing the located in the right main bronchus appearing as a oval radio opacity within the right main bronchus. Coming to the pathologies on the contralateral lung, that there may be associated compensatory hyperinflation following surgical lobectomy or collapse of the contralateral lung, or there may be contralateral pleural effusion, mainly the layering pleural effusion, leading to the unilateral hyperlucency seen on the contralateral skin. So this is the chest X-ray radiography of left lung collapse in a patient, in a newborn girl with worsening respiratory distress after intubation. So this frontal chest radiography shows hyperlucent right side of the hemithorax and completely opacified left hemithorax. This is mainly hydrogenic because of the intubation and with the endotracheal tube intubation, the tip of the endotracheal tube is seen in the right main bronchus, resulting in hyperventilation of the right lung and collapse of the left side of the lung. So while intubation, we have to be a little bit cautious in identifying the in positioning the tip of the endotracheal tube so that the aeration should happen to the both of the lung and intubation into the ipsilateral or right main bronchus may cause worsening distress as well as the collapse of the opposite side of the lung, giving the unilateral hyperlucency. This is a chest X-ray radiography of another patient showing increased lucency on the right side of the lung, whereas the pathology is mainly on the left side. Because of the appearing of the layering pleural effusion, the patient is giving the appearance that the right hemithorax is hyperlucent. Coming to the summary, a variety of abnormalities of chest wall, lung parenchyma, and pulmonary vessels, central airway, and mediastinum can result in unilateral hyperlucent lung. So, understanding the spectrum of this condition and the characteristic imaging finding can permit yearly and accurate diagnosis, which in turn can result in optimal patient management. Coming to the flow chart of approach to the unilateral hypolucent hemithorax. And the first thing we have to see is patient rotation. And the patient rotation can be identified by measuring the distance between the spinous process to the medial end of the clavicle. It has to be equal on both sides. And for example, if it is increased on one side, that means the patient is rotated to that side and leading to unilateral hypolucency. To avoid this thing, the X-ray has to be taken in proper positioning with deep inspiration. And this patient rotation may also be seen in case of scoliosis, where the patients already having some spinal deformity and patients won't be able to stand straight for the X-ray and causing the unilateral hypolucency. And if patient rotation and other technical factors has been ruled out, the other causes we have to rule out. We have to proceed the X-ray and see for any radio opaque contralateral hemithorax. So the pathology will be of unilateral hypolucency, maybe not on the same side pathology because of the pathology on the opposite side lung. The ipsilateral side may appear hypolucent. So the contralateral hemithorax pathology includes layering pleural effusion or unilateral pulmonary venous atresia. So this effusion on the left side may cause the hypolucent hemithorax on the right side. So you should always have to look for the pathological side and not the hypolucent side. And you have to check whether which side is pathological and we have to evaluate further. If the radiopaque contralateral hemithorax is absent, then we have to see signs for air trapping. So, I'm sorry. So the signs of air trapping is there. Then we have to look for airway causes. It may be due to the bronchial obstruction or extrinsic compression or bronchial narrowing. So this extrinsic compression is mainly caused by the mediastinal or a hilar lymph node or any hilar or mediastinal masses that is causing the ipsilateral bronchial narrowing as well as air trapping on the ipsilateral side, or there may be foreign body ingestion, most commonly seen in case of children, and these incisions may go into the right main bronchus because of the anatomical positioning of the right main bronchus, leading to air trapping on the ipsilateral side, giving rise to ipsilateral hyperlucence lung. If air trapping sign is absent, then we have to see for small or absent contralateral lung. If small or absent contralateral lung is there, then main causes includes majority of the causes are congenital, which may be pulmonary agenesis or pulmonary hyperplasia that's happening in congenital, leading to the ipsilateral. For example, right side lung pulmonary agenesis is hyperplasia is there. That affected side lung development itself is smaller, so the affected hemithorax will be small, and lung development on the contralateral side may appear hyperlucent because of the hypertrophy, and they may also be associated with mediastinal shift to the ipsilateral side. That is the, and there may be proximal interpretation of pulmonary artery, or there may be Schmitter syndromes. If the small or absent contralateral lung pathology is ruled out, then other unilateral lung abnormality pathological causes we have to see. That includes parenchymal causes or congenital pulmonary lymphangiectasia or anterior pneumothorax or diaphragmatic hernia or rupture or Poland syndrome. So in Poland syndrome, that ipsilateral muscles may be absent, so more X-rays will penetrate on the affected side, leading to unilateral hypolucency. In case of diaphragmatic hernia or rupture, the diaphragm abdominal content may herniate, and as well as there may be the mediastinal shift will be seen, leading to the ipsilateral hypolucency. And in case of pneumothorax, the air will get collected in the pleural spaces, and there will be absence of bronchial markings will be seen, and the congenital other causes includes congenital pulmonary lymphangiectasia and parenchymal causes. It may be acquired, or there may be congenital causes that may causes unilateral unilateral hyperlucent hemithorax. Thank you.